We also have choices for wavefront modifying, pinhole optics. These are a little bit more forgiving IOLs, but there's also a little bit of a lower real world performance. Accommodating IOLs, these are sort of the grandfather IOLs that have been around for more than 20 years, still useful in select patient populations. And sort of the newest kid on the block here, at least in the United States, is the light adjustable lens, which even though it's not technically a presbyopia-correcting lens, using a monovision, blended vision option with adjustments and lock-ins can be very appropriate in certain and select patient populations. Let's talk a little bit about corneal astigmatism. Well, we're all familiar with the type and the meridian of the corneal astigmatism, with the rule versus against the rule and oblique. So what's new? Well, we know with the rule, we'd want to slightly undertreat in younger patients, against the rule, aggressively treat in all patients. We have a lot of options: toric IOLs, LRIs, femtosecond laser, bioptics, where we combine lens-based surgery followed by LVC, and we talked about the LAL. In general, you want to try to minimize the astigmatism, even if it means slightly flipping the axis, especially flipping from against the rule to with the rule. In recent years, we know there's an increasing role of PCA, or posterior corneal astigmatism, which can mask or exaggerate anterior corneal astigmatism. Some of the previous toric calculators made assumptions of the PCA. We now have newer devices like the TK and Scheimpflug, which give us TCRP, which can give us some more accurate measurements. But whether or not they improve formulas remains to be seen, because the conundrum is the existing formulas were trained on anterior K measurements with assumptions about the posterior cornea. We don't really have now newer modifications for some of the toric formulas, and that remains a work in progress. But in general, newer toric formulas we have do incorporate and account for posterior corneal astigmatism. And finally, regular versus irregular astigmatism. And this is where tomography can be very helpful, because topography can give us an idea of this patient's anterior astigmatism, but we know that there are posterior surface changes that can be sort of lying beneath the surface. So again, we want to look for patients with that symmetric bow tie, which is predictable for toric correction. What we want to avoid are that skewed, asymmetric, distorted patterns of irregular astigmatism. Confirm with multiple modalities such as topography, tomography. But the biggest thing is that these are patients we cannot correct with IOL-based surgery. These are patients that classically needed an RGP or scleral, but now we can maybe use topo-guided laser vision correction to treat some of these irregular astigmatism patients. But for most cataract surgeons, it's important to make sure this patient, that a prospective candidate for PCIOL does not have irregular astigmatism, because that will lead to pseudophakic unhappiness. Now, sometimes the changes can be a little bit more subtle. So here we have this patient on biometry, seems like they're a good candidate, very low amount of astigmatism in the right eye, fairly decent amount of astigmatism on the anterior side, but look at the TK value that seems to be much more higher here, almost adding a full diopter of astigmatism. And when we look at this patient on tomography, we can see that the right eye looks kind of okay, maybe a little bit of a skew if you squint, nothing on the anterior surface elevation map, but certainly there's a skew here in the left eye, and this may be almost coming a formed fruste keratoconus or some other thing that may be going on. It's not to say you can't do a PCIOL in this patient, but I think your selection will change as compared to that ideal example patient that we saw. Here's another example of a patient again that we can see here. This arrow was meant to point at the inferior steepening here and the posterior elevation. So this is a patient with a subtle posterior float, Kmax slightly higher, and we see that the Bell and Ambrosio is kind of lighting up here, showing us a yellow flag, indicating that this patient, again, may not be the best candidate for a diffractive optics. Could probably get away with putting a toric, because this is regular astigmatism here. So again, we can see how we can leverage some of this technology to determine who's a candidate and who's not a candidate. And again, this is that same patient looking on the Bell and Ambrosio. We have multiple yellow flags that light up here of back surface and front surface changes. And I really like looking at this map, because you can highlight what you are considering here as a possible problem. Now, when we exclude the central 3 millimeters, we see that's much more magnified. And when it's compared to an age-matched database, we can see that this patient is kind of approaching a formed fruste or a mild keratoconus variant. Again, doesn't mean they need to be cross-linked or need to get corneal transplant, but just something to be mindful of if this patient now presents for PC-IOL consideration here. So again, not an immediate disqualifier, but would be very cautious about using ringed PC-IOLs. What are other things to look for? So subtle corneal disease, so EBMD, Salzmann's, previous laser vision correction. EBMD can really skew what we're seeing here. So here we have this patient that comes in, seems like very minimal astigmatism. When we look at the patient on tomography, we can see that there's quite a bit of irregularity highlighted by where the arrow is pointing here. This is a patient that has EBMD. It's important to now treat that with a superficial keratectomy, PTK, so that we've regularized or normalized the astigmatism before now considering diffractive optics PC-IOLs. The analyzed page helps. Again, this is why I said that page is so important, because here we can see in this patient that was shown in the previous slide that the dots that indicate the quality of the keratometry are not very good. And so this is a patient that clearly had EBMD, needed a DBSK, a diamond burst assisted superficial keratectomy. And 3 months later, when this patient comes back, we can see, again, on the right side are the old measurements, on the left side are the post-SK measurements. What we notice is, first of all, the quality of the improvement of the measurements has definitely improved. In fact, the measurement failed on the central topography before surgery. We didn't even get a read, and now we actually are getting a read. But interestingly, this patient actually had an increase in astigmatism after we did the SK, and now you can actually think about doing things like a toric or other surgical maneuvers to treat that astigmatism, especially if it is repeatable. This is a patient, again, had higher angle alpha. We advised no diffractive optics, opted for a monovision option with a toric IOL there to treat that amount of astigmatism. So again, we're going to talk about angle alpha here in just a little bit, and actually it comes up on the next slide. So what's an important metric, I think, and this is a busy slide. I'm going to try to talk through it and allow you to look at the slide or maybe even pause here. But we know that higher order aberrations are very important. These are subtle optical imperfections that affect the quality of the vision. So we can't refract these out. These are the patients that kind of come in unhappy, even though they're seeing 20/20 minus or 20/25 plus, and but they just feel that the quality of the vision is very bad. Well, why does that happen? Well, we talked about spherical aberration, but there's also coma and trefoil, I think, are important metrics to think about, because higher amounts of these HOAs are going to lead to a greater risk of glare and halos and a poor tolerance for multifocal and diffractive optics PC-IOL. So in general, a coma or trefoil that's greater than 0.3 and the total HOAs greater than 0.5 should steer us away from diffractive optics and towards some other PC-IOL type options. Shifting gears here to the angle kappa and angle alpha, something which confuses a lot of surgeons, especially trainees, is what the heck are these angles? Well, angle alpha is the difference between the pupillary axis and the visual axis. Technically, it's the line of sight, because the visual axis gets broken up through the nodal points. So really what we can measure is the line of sight. But I think for so many years, we've always used the word visual axis. So I'll use it, even though I give the disclaimer that it's not the most academically correct term. But in general, the pupillary axis and the visual axis difference, that's angle kappa. Angle alpha is going to be the difference between the visual axis and the optical axis, or in this case, the limbal center here. So large angles are going to lead to a higher chance of dysphotopsias. I think in the past couple of years, there's been a greater awareness of angle kappa, which is, again, the pupillary and the visual axis. But if you think about it more, where does the IOL center? It's going to center in the center of the optical axis. So ideally, you want your line of sight, your visual axis, to be straight through that optical axis. So I would actually argue and actually present to you all that the angle alpha is going to be much more important. So if you have a patient with a large angle alpha, there's a higher chance that he or she is going to look away from the center of the optic and is going to look through those rings, and that's going to lead to higher chances of pseudophakic unhappiness, especially with IOLs that have more rings. So something like a Symphony may be a better option on somebody's got like a 0.55 angle alpha, because it may be a little bit more forgiving or tolerant. So again, a busy slide here. Again, just repeated the definitions of angle alpha and angle kappa there. But while there's some disagreement and discussion in the literature about exact cutoff values, we do know that higher rates of post-operative photophenomena. In other words, these are the glare, the halos, the starbursts, these unhappy patients after surgery. These are patients that have higher angle alpha values. So usually greater than 0.4 increases the risk of photic phenomenon and decreased subjective visual quality. Again, not all lenses behave the same. So a little rubric I've kind of given here is less than 0.3 is green, nothing to really worry about. Between 0.3 to 0.5 is kind of a yellow light of a caution, but greater than 0.5 millimeters, I would definitely try to avoid ringed PC-IOLs. Now, some of the newer ringed PC-IOLs may tolerate some offsets, but again, you want to make sure you spend some time screening and counseling the patient that this may actually happen. Finally, a word here, there's a nice paper that was put out in JRS in 2023 by the group from France, which showed that angle kappa really had no impact on post-operative visual satisfaction in patients with multifocal lenses. And they actually said that angle kappa should not be used as a single variable to determine who's a multifocal IOL candidate or not. I would agree with that. I think the angle alpha is really our culprit here, and the kappa, I think, for several years has been kind of getting a bad rap. So I would say we really need to focus our attention on the angle alpha more than the angle kappa. Now you may think, I don't have a fancy device to get these measurements. Well, if you have an IOL master or a lens star, if you look at your IX and your IY values, you can use sort of a little cheat sheet, a little cheat code to quickly calculate the value. Now, technically, we have to use Pythagorean theorem, but who has time to do that? And I certainly am not mentally smart enough to do that calculation of squaring these numbers in my head and then taking the square root of the sum. So what's a shortcut that we can do? Well, again, we have to technically use a Pythagorean theorem, but a little shortcut that we can do is we can take the absolute value of the IX and the IY value. So it doesn't matter whether we see minus signs or plus signs, just take the absolute value, summate them, okay, and that's going to give you a good measurement of the angle alpha. Now, if one of the values is greater than 0.3, then subtract an additional 0.1. So for this right eye, we would do 0.6 and 0.2, get 0.8, but we would subtract 0.1, and we actually get 0.7. And we actually plug this in and do the calculation, comes out to be about 0.63. So if anything, you'll slightly overestimate, but this tends to be a pretty good rule of thumb. And same thing, when we apply that calculation to the left eye, we get a similar number there for the left eye. Again, showing that this is a relatively higher angle alpha, and we want to be very careful about using diffractive optics. Now, we may think, well, maybe this device measured it for some reason. So let's see if our shortcut, if we scan this eye here with other devices, if we also get a higher angle alpha. This is that same patient. When we look at the pentacam, again, chord alpha here is 0.66 in the right eye. For the left eye, about 0.54. When we use the eye trace there for the right eye, also kind of 0.5. So just showing that this is a patient here that has a higher angle alpha, that we would maybe not want to use diffractive optics and instead think about a different type of a PC-IOL or even a monofocal type of option there. What about spherical aberration? So I kind of showed you there on the left side this table of different lens manufacturers ranging from the most amount of negative spherical aberration built into over here. So what are the considerations? Well, the clinical implication here for the three most popularly implanted lenses in the US is that all three manufacturers have different amounts of negative spherical aberration that is built into the lens. And they have different philosophical outlooks, as if to say that some amount of pseudophakic spherical aberration on the plus side may be helpful to kind of create a little bit of depth of field and create, improve some intermediate and near vision. So in general, we want to kind of choose based on the desired pseudophakic ocular spherical aberration, the pupil behavior, and tolerance for decentration of that lens. Now, some of you may be like, well, gosh, this is going to create a huge problem in my practice. I still want to emphasize that correcting refractive error is going to be more important than correcting spherical aberration and thinking about that. But nonetheless, I think this is very important for patients after laser vision correction when they have very high amounts of spherical aberration. So using something like a lens that corrects a lot of that spherical aberration would be very helpful. Again, that's for myopic laser vision correction. Let's say if somebody has had a hyperopic laser vision correction, we would actually want to maybe do an aberration neutral, or maybe even put in a spherical IOL here, or like the Rayner here, which has the EMV, which has a little bit of plus spherical aberration to kind of correct some of that spherical aberration more closer towards zero. So again, there's a great debate about how much spherical aberration is imperfectly perfect for every single patient. What about laser vision corrections patients and PC-IOL? So the old thinking, I think, it was kind of taboo for patients who had undergone previous LASIK, PRK to receive a PC-IOL. And I think that's kind of changed now. I think with careful selection and screening, these patients can still get a PC-IOL. But our preoperative assessment, I think, really has to go beyond biometry. We need to think about astigmatism, higher order aberrations, angle alpha, spherical aberration. We have to make sure we optimize their ocular surface. But this table I've kind of put below, this is just sort of my suggestion. This is not published anywhere. This is just kind of looking through the literature and also personal experience for who would be a good candidate for which kind of lens, and some of the considerations to kind of think about here for diffractive optics versus non-diffractive optics, modifying, wavefront modifying lenses, or even just doing now with the advent of the monofocal plus lenses. In the US, we have now the Invista Aspire, we've got iHands. So we have some options on these monofocal plus lenses that can give patients improved intermediate vision and still maintain excellent distance vision as well. So again, not a true PC-IOL, but kind of like a PC-IOL light, which you can't really charge for, but nonetheless, you can deliver a good product to the patient. That segues into now kind of the last part of this talk, which is patients' lifestyle and visual goals. I think just as important as we did all that scientific and clinical stuff, the human aspect of understanding our patients' visual and lifestyle goals is critically important. So we make sure we need to understand, what do they like to do? Do they do a lot of computer work versus outdoor activities, fine detail work? What are their vision priorities? Do they travel a lot? Do they drive at nighttime? Glasses expectations. So how important is full spectacle independence? This is very important because we know some of the lenses may give us a better chance at full spectacle independence, but it's like trying to land a plane on an aircraft carrier rather than an airfield. So the fit and the restrictions are a lot tighter, and we have to make sure we choose those patients much more correctly. If you have a patient that's a little bit more easygoing, it's like landing the plane on an airfield, you have a little bit more leeway for error. So making sure the patient has, you as a surgeon understanding the patient's expectations for full spectacle independence. That segues into the personality fit of the patient. I think now the modern cataract surgeon also has to be like a part-time psychiatrist or a lifestyle coach to figure out what are these patients' personalities and who's going to do what, who's going to do well with what particular type of lens. So bottom line, I think in 2025 now, surgeons can't be married to just one PC-IOL or one manufacturer or what have you. We have to be, I think, experienced and knowledgeable about all of these different PC-IOLs and the various technologies, and leverage these strengths and weaknesses to develop a custom surgical plan for every single patient that kind of comes into our practice. So we have to admit, I think in 2025, if you're a successful PC-IOL surgeon, it has absolutely nothing to do, I would say, with how fast and how amazing of a surgeon you are in the operating room. But how do we determine success? I think the key to success with these lenses are your objective knowledge. And that's kind of the first part of this talk. That was a talk I give over 2 hours, condensed into about 15 minutes. But our objective knowledge now, especially with understanding how to interpret some of these ancillary imaging and corneal topography, I think is very, very critical. But equally important, I think, this is why I would say, thankfully, AI is never going to replace us as surgeons, is the subjective connection. So how do we approach these patients here? And this is the mnemonic that I kind of like to teach here is just tell everyone, choose fairly. So this is a 5-letter acronym, mnemonic, whatever you want to call it here. So This incorporates the judgment. So that's the clinical judgment that we spent the first part of this talk talking about. The transparency, I think making sure we explain to a patient that every one of these lenses has pluses and minuses. There's no such thing as a perfect lens. That's where our ethics kind of come into play here. That leads us to empathy and listening. So again, the chair time and the brain time is what these patients are paying for out of pocket. As again, very little to do with how amazing, how quick of a surgeon you are. They are paying extra so you can sit with them, talk to them, and understand what they want both before surgery and also after surgery. The C is going to stand for collaborative decisions, kind of giving patients some input on shared decision making and explaining to them, even if you ultimately choose which lens out of that schematic there that you think is going to be good for them, explaining to them why you've done that so they have some participation in that decision making. And finally, follow-up commitment. I know it's very easy to do things like co-managing and sending a patient back to referring providers. And I think many of us do that, but sort of committing to the patient that if they have problems, we're going to see them, we are going to examine them, we're going to do what we can using our clinical and surgical knowledge to try to, still deliver the best possible outcome rather than just say that, there's somebody else's problem. Again, so many choices. We have to know all of these choices and figure out which choice we want to use for every single patient here. So I'm going to run through 3 quick examples here on which type of a lens would be appropriate here. Again, there's so many more examples we can do, but just for the sake of time. So case 1 here, we've got a 68-year-old female engineer. She really wants to have good vision for fine detail, minimal glasses, things we see on the exam, healthy macula, mild coma, but she does have a little bit of a higher angle alpha. And because she's an engineer, she has this very perfectionist mentality. So my assessment, I would say this patient may be a very poor candidate for diffractive optics IOL. So we may want to use an EDOF without rings, like a wavefront modifying or a pinhole optics, maybe do a monofocal plus. Could certainly do a monovision option. Again, engineers and type A personalities may not like that, but this is where something like an LAL would allow them to maybe trial that out. And if this patient doesn't like it, we can kind of give them distance vision here. So, but what bottom line is that we would want to emphasize the contrast and clarity over independence, because again, if you're trying to be completely independent from glasses, you may have to sacrifice a little bit of contrast and detail. So that would be kind of the approach for that first patient. Our second example would be a 72-year-old male. He's a golfer. He wants really independence for distance and intermediate. And we see findings are relatively straightforward there. And so this would be a patient who would be a very good candidate for diffractive optics. So again, maybe this patient you could do a little bit of a mix and match approach. For example, maybe doing like a symphony in one eye and a synergy or odyssey in the other eye. We can get creative with that sort of approach to leverage the strengths of one lens that has good distance and intermediate with the strengths of another lens which has good near to kind of give them that good binocular range of vision. And finally, case 3, this is a 60-year-old female. She's a lawyer. Again, very similar to our first patient, but has the goals for perfect vision at all distances. We see some different metrics there, but to me, the most important thing is that she's done monovision contact lenses for 15 years. So she has dry eye and a higher amount of higher order aberrations. So there's a higher risk this patient may be unhappy. So here, this is a patient we definitely need to treat the ocular surface and maybe just keep her in monovision with monofocal plus IOLs, possible LAL, maybe an Apthera could also be considered. So these are sort of the option here. Basically, you want to avoid diffractive optics in our third patient. So the conversation matters. The final choice can be overwhelming. So this is where we want to use confident, reassuring, and empathic words. We don't want to be kind of like a sleazy used car salesman type of approach, but we want to make sure that the patient, again, is also, receiving that confidence and that reassurance. So instead of telling them this is the kind of lens you need, I think using our words like, here's why I think this is the best lens option for you. But we also may have patients who are super motivated because their spouse or neighbor got a fancy pants lens and they want the same thing. But if we see that they're not a good candidate, we have to be the adult in the room and tell them that, hey, I think this lens may not be right for your eyes. I think showing imaging when relevant and using analogies can be very helpful to kind of educate patients, because again, it's overwhelming for us as surgeons. Imagine how overwhelming it is for patients as they're trying to make a decision in your chair in that 5 to 10 minutes of FaceTime they have with you. So I know I've gone a little bit over, but I think it was very helpful and very useful for us to kind of understand both the clinical and the subjective features here. So to summarize, I think what we talked about in this first lecture here is we talked about an update on new clinical information, including diagnostic and ancillary devices that every surgeon who wants to do PC-IOLs, I would argue, needs to understand in order to have success. And we talked about astigmatism, corneal HOAs, optical angles, again, angle alpha being much, much more important than angle kappa, spherical aberration considerations, and carefully screening and selecting amongst our post-laser vision correction patients. I think we have to have knowledge of all of the currently available PC-IOLs, and this problem is only going to become worse as we have more lenses to come. So it's exciting that we have new things that we can offer our patients, but the burden of knowledge, unfortunately, now increases with each day for us as surgeons, that we have to be knowledgeable about these lenses. The importance of human connection, again, just tell everyone, choose fairly, and we kind of went through that acronym on one of the previous slides.
Wow, what a great piece of education to kick us off. And we're going to hear from Dr. Riaz in just a little second. I'm just going to pull up a QR code on the screen. I've also popped a link into the chat. We'd love some feedback on the session today. So you might need that link if you're ducking out early, or if you're not staying right until the end. But it's right there. It'll allow you to give us some feedback, complete some of those little polls again, and claim a CME certificate. We'd really appreciate it if you can fill it out at some point during this session. So we're going to move straight into the second session we're going to be looking at today. And at the end of this talk, we're going to have time with Professor Riaz for you to ask some questions. So please pop your questions into the chat box or the comments if you're joining on LinkedIn, X, or Facebook, or YouTube, and we'll pose them to Professor Riaz afterwards. So the next talk is on personalized perioperative support for presbyopia-correcting intraocular lens success. Prof. Riaz.
Hello, and welcome to Lecture 2 of this series put on by MedAll Education about presbyopia-correcting IOLs and the latest advances. Our second talk will be titled Personalized Perioperative Support for Presbyopia-Correcting IOL Success. This talk will build off of some of the information we discussed in the first lecture, so I would highly encourage you to make sure you've listened to the first talk, because it serves as a foundation for this second lecture. Without further ado, we'll go ahead and proceed. So in this talk, what are some of the things we want to try to learn? So the first thing is we want to identify some key information, key components of preoperative counseling for potential PC-IOL patients. This will help us to develop a personalized perioperative, so perioperative means both pre, intra, and post-operative care plan. We can communicate with patients realistic post-operative outcomes. We can recognize some early signs of pseudophakic unhappiness or maladaptation, which I would argue is as equally important as being able to do surgery correctly. And finally, we'll talk a little bit about utilizing clinical decision tools and some validated surveys to improve the process both for us and for our patients. So this is where we now have to merge clinical care with patient-centered care. We know there's a rising interest in PC-IOLs both amongst patients and surgeons. So we look at, this is a survey put on by the ESCRS, the European Society of Cataract and Refractive Surgery. We can just see here the rising interest in different types of lenses and how that's changed over the past 9 to 10 years. So again, the challenge is patient satisfaction depends on more than our surgical skills. And this is, I think, where all of us have to be humble enough and understand that it's not how fast and how good we are as surgeons, but it is, can we leverage our knowledge of all of the PC-IOL technology? Do we know the strengths and weaknesses of all these, of every single PC-IOL model that's available, and ultimately use that information to now ask ourselves this very important question: how can we make our practice different? What makes us different? And I would argue that the successful practice is the one that provides both structured and personalized support to guide and help patients through this entire process. So the pre-visit preparation, optimizing the patient. And this is where something I think where we have to start the journey even before the patient steps foot in our office or in our clinic. So one of the things we can do is to pre-schedule days or blocks for PC-IOL evaluations, understanding that these patients may need more chair time, more brain time. So we may not want to schedule them in the middle of a busy clinic day when we're seeing other pathology. Many of us may be cornea, glaucoma specialists. We're seeing some of those patients that are different level of pathology and different level of need. So maybe lightening the clinical load for these PC-IOL evaluations for a couple of reasons. One, less patient wait time. They don't have to wait 2 hours just to come say hello. Now it's only a 30-minute wait, and they're going to be much more happier and friendly and more receptive to the conversation that we're about to have. This also allows them to have more chair time with the surgeons so that we as the clinician are not feeling rushed that, we've got 12 other patients that are waiting and our staff is giving us that annoying and dirty look that, come on, doc, hurry up, we got to get out of here. But allowing ourselves and the patients to have enough pre-surgical chair time, I think, is very important. Office ambiance is very important. And I noticed I didn't put details there because I think I want to be mindful that all of us practice in different socioeconomic areas. So I think each one of us know what kind of an ambiance will make the office better, ranging from the lighting to the painting. But I think in general, we want to make sure that we have an ambiance that is welcoming, that is not rushing the patients, and definitely not wanting to make patients feel that they're here to buy a car and they better close the deal. Otherwise, they're going to miss out on something amazing. And this is where we want to train staff to set expectations, to be enthusiastic, but not sales-like. We may want to identify some key technicians who just have maybe a more natural, bubbly personality that is going to, interact better with patients to kind of serve as patient concierges when these patients kind of come in for a PC-IOL evaluation. So again, these are little things we can do to try to make the experience better. I think educational tools are very helpful. Not just giving pre-consultation handouts that they can read while waiting for you. Now in the era of QR codes and things like that, we may be able to send them some of those videos before surgery. I know many practices where the surgeon themselves has recorded like a conversation, a little education about the different PC-IOL options that patients can watch even before they come in or while they're waiting in the waiting room. And I think that's a very clever idea that they can do. But waiting room videos, I think, can be very, very helpful. And a big thing that can help guide the discussion is sometimes, patients don't know what lens they want, or they may think, well, my spouse had lens X, so I must get lens X. If we kind of use some patient goals surveys, this can help clue in on what factors are important to patients, what are their expectations after surgery, and sometimes even critically allow us to identify those red flag troublemaker patients that in all seriousness may not be good candidates for these PC-IOLs. So this is a survey that I use. I just kind of put that up there. Again, I'm sure many people have different surveys. This is just modification of some of the other surveys that I've seen out there. But this helps us, I think, to understand what are their distance vision goals, near vision goals here. I like this question the most here, where, let's say they don't want premium IOLs and, they can kind of skip that. We don't have to talk much further, but I also kind of like this because this kind of gives me an understanding of, are they easygoing, relaxed patient? If they circle all just over here, I don't want to have to wear glasses for anything, and I want to have, X-ray Superman-like vision. I mean, that may be a patient with unrealistic expectations that may not be the best candidate here. So And that's where I think which of the following describes your personality type. Usually I want patients to kind of circle these two, maybe these three, and then if they circle this, it's a whole different conversation that we're going to have. So different surveys are out there. I just showed mine if that's helpful for people. But let's move on here to personalizing communication. So tailoring to goals. So example of making sure that our counseling is directed to the patient's lifestyle. So this is, again, the knowledge of the various strategies for presbyopia correction is crucial. Knowing the type of PCIOL for patients' lifestyle and what goals they have after surgery. And this is where, again, we should not shy away from monovision and blended vision options, which can still be a good choice for many patients. We should address expectations, realistic versus aspirational. I think we want to get away from using words like 20/20 or 6/6, and instead kind of talking about reading a text message, reading a menu in a dimly lit restaurant. Those are going to be important things so that patients understand what does that mean, rather than numbers that for most patients probably mean very little. Using our language to frame things positively. So again, this is a way we can be honest without overselling. So when we talk about a PCIOL, I like to use the phrase, we're trying to decrease the need for glasses, and emphasizing the word decrease, rather than simply saying, you know what, you won't ever have to wear glasses again. And sometimes when patients are unhappy after their surgery, and I see a lot of patients on referral for pseudophakic unhappiness, one of the most common things they complain about is they feel they were told that I never have to wear glasses again. I've got to wear readers now. I've got to do this. So instead, kind of framing it as decrease the need for glasses, I think is very helpful. And then each one of us, I think, can develop an in-clinic script that balances information, the pros and cons. In general, research has shown that you want to speak for about 30 seconds to 2 minutes before allowing the patient to respond. I found usually mentally thinking I'm going to speak for about a minute as I'm lecturing the patient on the different lens options and pausing, asking them, hey, do you have any questions? Does this make sense? Can be very helpful, rather than we kind of go into this 5-minute soliloquy, and by the end of it, patients have, we've lost their attention. They're not sure what they want to do, and they just kind of go for, well, just give me what lens insurance pays for, and they kind of, leave, and you feel you've wasted all these efforts. So personalizing the communication, I think, is so critical for success with these patients. So I've written here a very, very, very rough guide. There's not enough space on the slide for me to put enough varies here, but a guide to matching PCIOL to patients' needs and their personality. So for example, here we see things like risk tolerance and lifestyle. So if somebody has, for example, a very moderate tolerance of photic phenomenon versus a low tolerance, this now, if they've got a good tolerance, we can think about diffractive optics. If they've got a low tolerance, we may want to use non-diffractive optics technologies, such as the ones that are listed over here. If their lifestyle is that, hey, I want to be able to see a multiple ranges of vision, then we may have to go down the diffractive optics route. Let's say they've got more importance for distance and intermediate. This is where some non-diffractive optics, but of course, if we do some blended vision, monovision, we may be able to get them all their ranges as well. Well, what are their visual expectations? Highly motivated, or, for reduced spectacle dependence at all distances versus distance and intermediate vision. It can also help guide that decision making. And this is where that personality type, I think, really helps. So the relaxed personality, I think, is going to be a very good candidate for the diffractive optics versus those personality types. I think any personality would be good for non-diffractive optics. But again, this is sort of a rough guide to sort of now help classify which type of a lens, which type of a PCIOL will work for which type of a patient personality. What do we need to do in the clinic here? Again, some of this is a little bit of a repeat from the first lecture, but making sure we have reviewed all of this information before we enter the patient's room. So make sure we have good, high quality biometry, especially making sure dry eye has been accounted for. Corneal imaging that we talked about in the first lecture here. Lens imaging, that's something that is optional. And I know some clinicians like to take a picture of the patient's cataract for documentation purposes. On the Pentacam, on the pre-op map, there is the PNS value, which can actually give score. iTrace also has a DLI score, dysfunctional lens index score. So some of the devices do have a metric that you can use to kind of determine how significant a patient's lens is. And again, look, OCT macula, maybe even OCT nerve, so you don't miss glaucoma. But what do we do in clinic? So again, we all are pretty good at doing slit lamp exam and examining the patient's eye, but before we enter the room, we should review the diagnostics so that when we enter the room, we want to approach the case like we're a custom home builder. So which features of the patient's anatomy or personality are favorable? What are we concerned about? What are our limitations? Just like a builder says, if the property is only this size, but a homeowner wants a 6,000 square foot house, well, you can't build on a very small piece of land that large of a home. So same thing when we're trying to determine who's going to be a good candidate. Understanding their diagnostic, their personality types are going to be very helpful. Again, this is where we build trust through clear, confident communication, like we talked about, just treating, fairly the acronym that we gave, and make a decision for the PCIOL or not, mutually with the patient. So personalized counseling and lens selection. So again, clear, honest, and tailored discussions. Using language like, here's why I'm recommending this lens. I think it's certainly reasonable to compare options such as lens X versus lens Y when appropriate, especially if the patient comes in asking for lens X, but you think they're going to be a better candidate for lens Y. Talk about the trade-offs and expectations. So trade-offs between things like diffractive optics where, hey, there's a higher chance you're going to be 20/20 at all ranges, but you may have a higher chance of glare and halos at nighttime. What are the expectations with a particular lens that, for example, with a wavefront modifying lens, there's very low chance of glare and halos, but you do lose a little bit of contrast sensitivity. So being very transparent about some of these risks, I think, is very important in that discussion we have. And again, identify when someone is not a good candidate. We oftentimes may judge success by how many patients we've converted into a PCIOL for cataract surgery, but I would say sometimes avoiding a poor outcome is also a success, at least for your sanity, perhaps, maybe not for your checkbook. That's where it leads me to our ethical foundation. So we still have to put patients first. And this is very difficult, I understand, with decreasing reimbursements, higher cost of practice that we all have, but we still have to remember the oath we swore when we became doctors is we have to put patients first. So no financial incentives, or you really like the rep that comes from company X, so you want to try to do as many lenses as you can from there. None of that should influence the IOL choice. Be transparent about why we're selecting a lens for a particular patient. Tell them about the price and the discussion of alternatives. Emphasize that if you do recommend a PCIOL, that you're doing it based on things like anatomy, lifestyle, and outcomes. And again, I would argue that the most successful premium IOL practices are not the ones that actually do the most premium IOLs. It's the ones that are built on an ethical foundation, which I think leads to success. Well, what about the surgical day experience? So again, kind of creating a calm and concierge level type of day. So I know some surgeons, for example, will book all their PCIOL patients on a certain day or on a certain block of time, maybe even budgeting a few extra minutes for those patients, so they're not kind of rushing them through and making them feel like they don't have time to ask questions. You know that many of these patients will inevitably ask you questions on the day of surgery, so you don't want to run behind. So whether that's putting them in the morning, putting them in the afternoon, maybe even have a separate day for PCIOL surgery can be very helpful. But on the day of the surgery, not rushing the patient through the process. Sometimes they may decide, they want to change their lens, and that can be very frustrating. But making sure we provide reassurance and providing them with attention. Now, some surgeons do this, others don't. Full disclosure, I don't do this, but I have several colleagues who do this. So they call these PCIOL patients on the night of surgery to check in on them, make sure they're doing okay. They give them their personal number that the patient can call, and that can be a little double-edged sword. Some patients only use that very judiciously. Others will start calling you for everything, such as they want to change their 8 o'clock appointment to a 9 o'clock appointment, and they just call you rather than calling your office or your secretary. So I put a little question mark there. Some surgeons like doing that because it provides reassurance to the patient that they should call only in case of emergencies. But you may end up getting put on a whole bunch of crank call lists and robocall lists if you give out your number to too many people. So use that as you will. Well, what about post-operative care? Again, I know many of us will do things like co-management, and I certainly do a good amount of that. But we want to make sure we maintain that excellence beyond surgery. So what are some things that we can do? Well, we can schedule post-op visits to minimize wait time. So maybe put them on a certain day or a certain time of day so they're not having to wait a long period of time. Or perhaps, you have a different location that you see, a different satellite you see these post-op patients so that they don't have to wait so long. Maybe giving them a direct contact, maybe having a dedicated call person or a phone number that they can call if they have questions with their drops, with changing their appointment time, that sort of thing here. And proactively managing concerns and reinforce expectations. So kind of, I'm a big believer talking about early wins. So instead of telling them, well, you're going to see 20/15 at all distances and you're going to be able to see through walls and everything, talk about what are some of the milestones. So we maybe want you to be able to read a menu in good light. We want you to be able to read your text messages and read a Kindle or a tablet type of a device, so without needing glasses. So emphasize some of these achievable early wins that they can understand that relates to their life rather than, oh, we want you to see 20/20 or 20/30 or whatever it might be. Give them some wins and achievable milestones that they can judge how their process is coming along. All right, this is a busy slide here, but you can see here in this case, this is a patient that's unhappy and the surgeon's also unhappy, but if we manage them, then both parties can be quite happy. So how do we troubleshoot post-operative unhappiness? I think this is where we have to start with listening. Again, this is why we're not AI robots or LLMs. We have to be able to listen to patients and clarify their concerns. Understanding photic phenomenon that are associated, I call these center of the lens problems, the glare, halos, and starbursts. These are different than dysphotopsias, which are more edge glare and edge shadow. These are sort of, edge of the lens problems. You can feel some reassurance that these problems happened not because you did bad surgery, but because the patient's bad. No, I'm kidding. It may be because perhaps we underestimated the impact of their ocular anatomy or some of those other factors like angle alpha. But that's why these photic phenomena in particular, the dysphotopsia is usually typically related to things like index of refraction of particular lenses. But this is where listening, I think, is very important. We definitely want to rule out ocular pathology like ocular surface disease, cystoid macular edema, posterior capsular opacification, and residual refractive error. Now, here's something I really want to emphasize. If a patient comes in on post-op day 1 and they say, "Doc, I've got glare and halos," yagging the posterior capsule is not the solution, right? I want to emphasize that because these are patients that may ultimately need more time to adjust, or they may need their lens exchanged for a different type of lens. Again, don't do laser vision correction if photic phenomena are the problem. Again, I see so many patients on referrals where they said from day 1 they had glare, halos, and you see that the angle alpha is like 0.7. They've had higher order aberrations, and they've undergone now multiple like PRK laser vision corrections that treat like -0.5, sometimes even a -0.25. And the surgeon thought by doing that, that's going to fix the patient's problem. So understanding photic phenomenon versus, dysphotopsias versus true ocular pathology. Now, if a patient is seeing well, again, this is where we have to be a psychiatrist, assess the neuroadaptation, reassess the adaptation timeline, manage anxiety that these patients have. And this is where the tincture of time can be your best friend. We want to make sure we optimize the optical quality, making sure the refraction was done correctly. All of us in our practice, I'm sure, have technicians that are amazing and others that are still kind of learning. And so you want to have your most experienced refractionist refract these patients. A contact lens trial may be helpful. Laser enhancement may be helpful if we truly have a refractive miss. Treating ocular surface, we've discussed that and you've heard that. But targeted education, this is where I think we want to normalize the symptoms when appropriate. We want to reset expectations when when it's necessary, but also do it in a tactful manner. And finally, let's not be afraid that if we have a patient that's truly unhappy with photic phenomenon, to go for an IOL exchange, especially if they've not been yagged. And that's something I think we have to understand, that comes with the territory, that if we're going to do premium IOLs, we're going to have to mentally budget that there's going to be some patients that are going to be unhappy, and we're going to have to do an IOL exchange. And there's no shame in that, as long as you and the patient have given it enough time for it to work. I'm usually kind of, if it's true photic phenomenon and not an anatomical problem. For example, what I mean by that, anatomical lens hasn't dislocated, I would wait for at least 4 to 6 months before going in and removing the lens. Of course, what makes this difficult, if there's concurrent PCO that's getting worse, you're tempted to yag, and hopefully that'll solve the problem. But if that problem existed from day one, it's probably not the PCO, it's probably the lens. So consider IOL exchange when appropriate and when all other solutions fail. So this is, again, kind of a very rough algorithm I've created here that may be helpful, these 5 different steps for these unhappy patients. Again, identify what's the main complaint. Ask open-ended question like, what's bothering you? And sometimes I say, everything's bothering me. My kids don't listen to me. And well, you can't solve that problem, but at least for their eye problems, you can try to solve some of these other problems here. So I like to kind of break it down into 2 categories. How does the eye see? So that's the blur, the glare, the halos. And then how does the eye feel? Right? That's the ocular surface. So again, some of these patients may have post-operative, dry eye. And so if we just kind of lump everything as dry eye, it's not going to solve the problem. So I typically ask the patient, what's bothering you? Is it how well you see or how well the eye feels? And that helps me now to target therapy appropriately. When we ask in step 2, like, what's bothering you right now? Actually, that should have been step 2 there, but I apologize. Step 1 should have been identifying the main complaint, and step 2 is to try to figure out how well the eye sees versus how well the eye feels. Step 3 is to identify some of the easy wins first. So if it's truly dry eye and it's reversible, we can treat that. If it's an issue of, let's say there's CME, treat that. We can do a spectacle or contact lens trial if it's a true refractive miss, to make sure that it's reproducible. And if it truly is, that's where we can do things like laser vision correction to treat the refractive miss. Step 4, manage neuroadaptation. So this is where we can use the tincture of time, give visual goals and milestones. And step 5 is to reassess at follow-up. If the patient has, again, persistent dissatisfaction or refractive error, that's where laser vision correction can help. But otherwise, IOL exchange, for better or for worse, it's part of the game. So to summarize, and a tailored experience, I think, begins even before the patient steps foot in your office. And we talked about some tools we can use, like videos and surveys and other patient handout materials. We can use clinical findings and lifestyle goals to guide some of our IOL recommendations. But nonetheless, it's still very important that we set realistic expectations and explain the trade-offs and understand there's no such thing as a perfect IOL. Integrity, transparency, and patient-first discussions are the foundations of trust. And I want to emphasize that's where the human aspect, I think, of this is so critical to success with these lenses. We want to make sure we create a calm, personalized experience from the time they check in to even something as a post-operative phone call. And finally, post-op care is just as important. Address concerns and be available even if you're co-managing these patients, and manage problems as they happen, whether it's a refractive problem, whether it's an ocular surface problem, or whether it's truly a lens problem. You are the surgeon, and you should be equipped with the know-how, both clinically and surgically, to be able to manage these problems. Hopefully they don't happen too often, but to be able to manage these problems when they happen. Thank you for your time.
We are really honored to have Dr. Riaz joining us. I'm just going to pull the QR code up for your CME certificate, which is on your screen right now. The link is in the chat if you're on MedAll. And we'd love a little bit of feedback on this session, you'll be able to claim your certificate. It'll take 2 seconds. We've got a few minutes for Q&A, Dr. Riaz, and I'm going to dive right in. Thank you so much for joining us and for some incredible presentations, and we've had some really lovely comments on your teaching so far. So thank you for joining us.
Thank you for having me.
I'm going to dive right in because we've not got a lot of time, but we really want to hear your thoughts. We've got some questions on angle alpha. When faced with conflicting or borderline angle alpha measurements, how do you make the final call on a patient's candidacy for a diffractive IOL?
Yeah, I think that's probably one of the most commonly asked questions. So, and I kind of showed how to measure angle alpha using the pentacam. If you have a biometer, you can use the IX and the IY values to calculate that by taking the absolute value of those numbers and adding them and then subtracting by 0.1. So if the IX, for example, is 0.3 and the IY is 0.3, you could add those up. Doesn't matter whether it's a minus sign or plus sign. That gives you 0.6, and you subtract another 0.1. So there, in that case, the angle alpha would be 0.5. So the question is about these borderlines. So I think it's relatively easier when it's like 0.1 or 0.2, and then you know that the line of sight and the visual axis, those are used interchangeably, but the optical axis and the visual axis are lined up. So now the question is, what if it's like a 0.45? And so I would say that's where you would have to now synthesize some of the other features. For example, does the patient have a lot of astigmatism? Do they have a lot of dry eye? Do they have other higher order aberrations? So if you kind of get multiple yellow flags in other areas as well, plus you have the yellow flag / borderline angle alpha, that's where I would, avoid a diffractive optics lens and perhaps choose another PC-IOL or some of the other technologies that we use. Now, let's say if the only thing that's kind of quote unquote borderline is the angle alpha, like a 0.45 or even up to like a 0.5, but everything else is great. They have the most pristine ocular surface. They've got less than 0.5 diopters of astigmatism. Everything else is good. I would say as long as you kind of discuss with the patient, ma'am, sir, that there's still a possibility you may be unhappy with the lens, but I think you'll be okay. I think it'd be okay to move forward with the diffractive optics IOL. So I think the key is discussion and documentation. Those are the 2 Ds you want to think about in these cases. Make sure you discuss. And most patients, when you explain to them, I think appreciate that insight. It's oftentimes they'll actually move forward. Sometimes some of us may be a little afraid that, they're not going to want to move forward and they're going to back out. But you'd be surprised at how many patients do want to move forward. And then if they are unhappy, they usually are not that unhappy because they feel that, hey, doc, you told me about this. I knew the risk I was taking. And now if we're going to go for an IOL exchange, they're not unhappy as compared to those patients that sort of have not been told or have been overpromised, and then they end up being unhappy. So that's kind of the how I would make that decision in those borderline cases.
We're just going to dive into the next question because we've got some brilliant ones here. What is your personal philosophy on managing spherical aberration? Do you aim to fully neutralize corneal spherical aberration or target a specific residual amount to enhance depth of focus?
Yeah, so this is a limited recording, right? You won't give me an hour to talk about this. I'm sure you'll hear me talk an hour about this. They've already heard me 2 talks. I think it's a brilliant question, and the answer is I don't think anybody knows. There's different schools of thought that any aberration, for example, is an aberration, therefore you must neutralize it as much as possible and get it to 0. That's, for example, the approach that the J&J platform takes with the minus 0.28 microns of negative spherical aberration that's built into it to try to bring it as close to 0 as possible. Most of the other companies have like a minus 0.18 or a minus 0.2 microns of negative spherical aberration, with the idea of leaving patients with a little bit of positive spherical aberration to kind of create that depth of focus, or the more preferred term, depth of field, to kind of improve some binocularity of vision, give improved near vision. We know from the old days when surgeons would put in spherical IOLs, and some of these are still around, it was not uncommon for patients to actually have 20/20 vision in J2, J3, though the contrast sensitivity and the some of the subjective vision was not as good. So So the answer to that, I think, is there's probably a Goldilocks number, which, I don't think we have fully understood because that number changes also based on the size of the optic, the size of the diffractive optic zone for some of these PCIOLs, also the patient's refractive error, and also the patient's pupil size in light or dark conditions. So I know I kind of threw out a lot of buzzwords and a lot of terms, but I think the bottom line is I don't think we have a magical number that we should aim for. But I think in general, somewhere around a 0.1 to 0.2 is probably a good amount for most patients. And then if we have another maybe MedAll follow-up lecture just on spherical aberration, we can kind of get into the pupil size, the lens platform. Not all lenses are the same. Being mindful of lens geometry. So for example, the ZC Boot platform, which the Symphony, Synergy, Odyssey, is a completely different lens architecture than what you have with the Invista platform, which is different than the Clarion or the SN60 platform. So there's a lot of things to sort of keep in mind. But I think in general, leaving patients with a small amount of positive spherical aberration does help their intermediate and near vision, especially then when leveraged with the power of some of the enhanced monofocals that we have these days.
You heard it here first. I know what our next session is going to be on. I've got one last question for you, which is really interesting, which is looking ahead. What emerging intraocular lens technology or diagnostic tool are you most excited about, and how do you see it changing presbyopia correction in the next 5 to 10 years?
Yeah, that's a very good question because I think, I've been in practice for about 10 years now, and I've seen so many new lenses, each one being promised to be this is the holy grail. We finally solved it, guys, and then you find out, each lens has sort of the same problems. So I think ultimately we have reached probably right now a point of diminishing returns unless we are able to truly restore accommodation, somehow magically find the elixir of youth and the fountain of youth and restore zonular ability to kind of contract and accommodate like we were when back in our early 20s. That's probably going to be the only way to kind of get there. Now there are some lenses that are on the market. I know that not on the market, at least in the US, but I know from some of our international colleagues that are trying to leverage that, like fluid-filled lenses that can respond to light that ambient light, and therefore the lens can change shape in that to sort of mimic sort of the next version of what something like the crystal lens was theoretically supposed to be able to do. So I think that's sort of the future development that I'm really interested to see. That can we sort of get real world data? I know if we've seen some clinical data, but real world data about these light responding fluid filled lenses that can sort of truly accommodate, and that way we don't have to deal with rings, we don't have to deal with diffractive optics and glare and halos, and this lens can sort of really be the next thing. So I think that's probably the thing I'm most excited about in terms of what may be coming down the pipeline. But otherwise, I think I showed the spider web map of all of the different lenses that are available. We have a lot of good choices, and I think the burden of knowledge is on us as for surgeons to try to realize that not just one lens will work for everybody, and we have to sort of find sort of a customized suit approach to try to deliver the needs for most patients.
Prof. Riaz, thank you so much for joining us today. Some incredible education, tackling some really great questions, and giving us a little bit of a forward picture of what's coming down the line. So thank you so much, and we'll hopefully see you on another MedAll education session sometime soon.
Thank you for having me, and thank you for those who joined, and have a wonderful rest of your day. Bye-bye.
Thank you. We have got another incredible speaker joining us today. We're also going to make it available on demand because we know that not everyone's going to be able to stay. So we're going to make this next session also available on demand to you. You'll be able to watch it anytime, anywhere on medalleducation.com. And we'll send you the link afterwards. But it gives me great pleasure to introduce our next speaker today, who is Professor Eric Donnenfeld, who is clinical professor at NYU, Grossman School of Medicine, trustee at the Geisel School of Medicine at Dartmouth, and founding partner at Ophthalmic Consultants of Long Island and Connecticut. And he's going to be sharing about latest clinical data to empower patient-centered selection. Professor Donnenfeld.
Hello, my name is Eric Donnenfeld. I'm a clinical professor of ophthalmology at NYU with a strong particular interest in cataract surgery and modern IOLs. I want to thank MedAll Ophthalmology for helping us with this presentation. I do consult with a variety of different companies, which you see listed here. The learning objective for this talk is to counsel patients on presbyopia-correcting IOLs, to talk about safety, efficacy, and performance, to support confidence decision-making, by aligning trial outcomes, and by integrating structured approaches to help patients feel informed, reassured, and aligned with their chosen treatment plan. So this is a dilemma that many physicians and patients have when they come in for cataract surgery: is what IOL should I choose for my cataract surgery? Well, there are many lenses that are adjustable. For patients who really aren't certain, I like the light adjustable lens. I think this is a remarkable lens. It's a lens that is inserted like any routine lens. It's a 3-piece lens that goes into the bag, but can be placed in the sulcus as well. So it's very good for complex surgery. And what this lens gives us is the ability to titrate the refractive results post-operatively. So you can actually go back and adjust visual acuity, not only changing the sphere, but changing the cylinder. So for patients who want monovision, or patients who've had previous LASIK where IOL calculations are more difficult, this has really become my go-to intraocular lens for cataract surgery. The surgery is uneventful, like normal surgery. And then post-operatively, these patients come in about 3 weeks after surgery for their adjustments, and then they lock in at 6 weeks post-operatively. These lenses require several visitations, and they require that the patient wear UV glasses when they're outside until the patients lock in. These adjustable lenses work by adjusting the shape of the lens by using an adjustment beam. The new lens has an active shield that blocks UV light except during the therapy, but we still recommend the use of sunglasses post-operatively, and the patients are provided these lenses. The light is shined to the eye. The photopolymerization takes place. There's diffusion and power change, changing the shape of the lens. Not only can you change sphere, you can change cylinder. So you can take a patient who says, I don't want monovision, and then post-operatively, you can actually give them monovision post-operatively. And then you finally lock in, usually about 6 weeks afterwards, at which time the patient can go out with UV light exposure without any issues. So let's start by talking about what's new in presbyopic intraocular lenses. There are basically 4 different forms of IOLs that vary based on the range spectrum. We have the minimal range spectrum, which is a monofocal lens. That's the government issue lens that's usually provided by most doctors. You have a monofocal plus, which is a lens that's not quite giving you enough to be called an EDOF lens, but it gives you a moderate range of vision. You have the EDOF lenses, which are premium lenses here in the United States. They give you an increased range of vision, usually with very little dysphotopsia. And then you have the full range of vision multifocal IOLs. They give patients distance, intermediate, and near, but there is often a qualitative loss of vision in these patients who complain of dimness or halos around lights. What I've learned in experience, having dealt with multifocal IOLs for decades, is that when patients want a presbyopic solution, they expect near, but they demand distance. And the rate-limiting step to most multifocal IOLs is quality of vision. If this patient could read beautifully but couldn't drive at night, they certainly wouldn't be happy. And the challenges with diffractive optics are dysphotopsias. Some light is misdirected and not focused on the retina. The not focused light creates disturbances, and this can be very problematic in low light conditions, such as driving at night. In addition, there's a loss of quality of vision, contrast loss. The split light results in reduction in light intensity, leading to a decrease in contrast sensitivity. And it's difficult to see clearly in low light situations. So how do we resolve these issues that patients present with? Well, one of the things I've learned is that the laws of optics cannot be changed. And the physical optics basically say that light is diffractive. And according to the economist Milton Friedman, there's no such thing as a free lunch, and the same thing applies to ophthalmology. There's no free lunch in intraocular lenses. Anything we get, we have to give up something different. But what I learned over a decade ago was that low-ad multifocal IOLs are better tolerated by people. And this is the study from the FDA that looked at 3 different lenses. This was the FDA approval trial of the Johnson & Johnson Tecnis lenses, looking at the 4.0 ad, the 3.25 ad, and the 2.75 ad. And what we found was that patients who had the lower ad were much more likely to have the lens again, 97% versus 87%. And when you looked at the Alcon lenses, exactly the same thing was seen with the Alcon Restore, that the 3.0 lenses patients were happier with was, again, they had less dysphotopsia. And that brought us to the next group of lenses, which were really invented just a couple of years ago, which are the extended depth of focus lenses. These lenses give a half a diopter or greater reading over a monofocal control. And their best corrected distance visual acuity is not inferior to a monofocal lens. So it basically gives very similar lens to a monofocal lens, but visual disturbances are not included. The first EDOF lens that was shown to have the same best corrected visual acuity as a monofocal was a Symphony lens. This lens had an elongated focus. We found that this lens tends to have a spider vision or a little bit more halo and glare, but in general, it's much better tolerated than the multifocals. They updated this lens by adding achromatic technology, reducing chromatic aberration, which improved the lens even more. The lens that has become the most popular EDOF lens to date is the Acrosoft IQ Vivity. This stretches the wavefront of the patients and gives a transition zone, and it's very well tolerated by most patients. It gives you 0.53 diopters of additional reading over a conventional lens, and you can see that the focus curve is moderately elongated. So these patients will say they have nice mid-range vision, and they feel very comfortable doing mid-range tasks. They can't really read up close unless you do monovision, but the mid-range vision is markedly improved. And spectacle independence obviously here is much greater. Certainly not 100%, only 21%, but much greater than a monofocal control. Binocular visual acuity, again, very similar to a monofocal lens. Now, the next lens that became available is not an EDOF lens. This is a monofocal plus lens, and this was the Eyhance lens, which is a lens that gives you a little additional reading. It's not a premium lens, but it doesn't cross that threshold of 0.5 diopters. It's visually indistinguishable from the ZC-BU Tecnis lens, and it has the same chromatic dispersion, spherical aberration, and A constant. But what it does do, it does give you a little bit more mid-range vision. Patients like it very much. It looks very similar to the Vivity lens. I find the quality of vision to be actually superb with this lens, and patients will almost always say that they have very good distance visual, and they can do some mid-range as well. The dysphotopsia profile is very similar to the Tecnis one piece. And this is a paper that I presented this past year at the European Society of Cataract and Refractive Surgery, looking at almost 1,500 patients who had cataract surgery with the Eyhance or a monofocal control. And what it shows very nicely is that the patients who got the ZC-BU, the monofocal lens, had a little bit better distance vision. 45% of patients seeing 20/16 versus 33%. So you do lose a little bit of distance vision with this lens, not a lot. The p-value is very small, but what they gain in return is a markedly improved uncorrected intermediate vision. 17% of patients seeing 2016 versus 3% in the control. And you can see here, 2020 visual acuity, 3.5 times more patients seeing 2020 with the monofocal plus eye-enhanced lens, and near vision again being improved. The next lens that became available in this category of monofocal plus was the Rayner EMV. This is a remarkable lens, FDA approved in 2021. It's a acrylic IOL, non-diffractive EDOF lens, and it uses positive spherical aberration rather than negative, which all the other lenses use to get extra mid-range vision. Invented by a good friend and well-known person, Graham Barrett. And you can see here the focus curve again is exaggerated, giving more mid-range vision. The light adjustable lens is a lens that I spoke to previously. A year ago came out with a light adjustable lens plus, which is an EDOF lens. It is a lens that gives a additional mid-range vision, and it works very nicely to achieve quality vision and good mid-range vision. So many of these patients can be very spectacle independent, especially if you do a little bit of mini monovision, because the dominant eye, where I usually use the LAL conventional lens, will give great distance vision, and the LAL Plus can be used to achieve extra reading vision as well. Now, there are a group of lenses that are on the horizon that I've done FDA trials with, and the Technis Puracy is a lens that's probably next to be approved in the United States. It's very similar to the eye-enhanced lens. It's a lens that gives a great dysphotopsia profile. The patients in our trial were extraordinarily happy with this lens. As a matter of fact, about as happy as I've ever seen. And the lens is, again, very similar to the conventional lenses that we have here. But you can see the extended depth of focus is actually much better than the eye-enhanced, and actually very similar to the Symphony. So this is a lens that gives much better quality of vision than the current Symphony lens, but with very minimal dysphotopsia profile. I think this will be an extremely useful lens in the near future. It should be approved hopefully during the calendar year coming up, and it's very readily available in Europe today. Here's a dysphotopsia profile of the lens showing very similar quality of vision to a one-piece lens. No glare and no significant halo. A lens which we're currently doing the FDA trials on is the Envista Aspire. This lens also will be an extended depth of focus lens, and has a very interesting central zone of increased power, and appears to be very well tolerated, and I think will be a very useful addition to our armamentarium in managing these patients. Now, the lenses that give the most reading are the multifocal IOLs, and there are 3 that are available in the United States: the PanOptix from Alcon, the Technis from Johnson & Johnson, and the Envista Envy from Bausch & Lomb. And I find all 3 of these lenses to be excellent. They all work very well. And one of the main concepts of a multifocal IOL is you've got to put it in the visual axis. And my good friend Vance Thompson has been very vocal about this. And what I try to do is center the lens, remove viscoelastic from behind the lens, and center it on the Purkinje image by having the patient look at the middle of the 3 lights on your operating microscope. These lenses work best when they are centered in the visual axis, like you see here. And here you can see me adjusting the lens to making sure it's right in the middle of the optic of the lens. A new lens that's coming is the Rayner Spiral or Galaxy IOL. This was designed with artificial intelligence and is the first trifocal lens that really doesn't use concentric rings. It uses a continuous spiral. And in our FDA trials, we found that these patients did extraordinarily well with a smooth range of vision. They could see distance, mid-range, and near with no diffractive light loss. And you can see by looking at the lens, and here's the Galaxy toric on the right and the trifocal toric on the left. You can barely see the rings on this lens. It had remarkable quality of vision. There are no surface steps, no continuous areas, and a very smooth ocular surface. And I do believe that this will be an extremely valuable trifocal lens, which will hopefully be available to us in the very near future. Again, showing the minimized dysphotopsia with this lens versus the trifocal. The last lens I want to speak about is the IC8, a thera pinhole lens. This is a Bausch & Lomb lens. It has a 1.36 millimeter aperture. And all you have to do is show a patient a pinhole in their office to show how this works. It filters out light in the periphery. For regular patients, it's very good for successful monovision patients. It is very astigmatism friendly, and you can have up to 1.5 diopters of cylinder, and the patients still do very well. But I find it most useful for patients who have irregular corneas. These are patients who would want a trifocal, but they can't. They've had arcade, they've had postoperative LASIK, and these are complex eyes that don't do well with conventional lenses. By eliminating the peripheral ways of light, these patients do extremely well. The low-hanging fruit for these patients, again, are irregular corneas, keratoconus, arcade, post-LASIK, trauma. And it's a very forgiving lens with what we call a large, elongated landing strip. These patients can be off by up to 3/4 of a diopter of sphere and still see 20/20, which is why when I place this lens, I usually aim for -75 to give great distance vision, but additional near vision as well. So let's finish with a case study now. This is a study of a patient who had radial keratotomy, among the most difficult patients that we manage. The patient was a high hyperope, obviously miserable, +5, and requests surgery to correct their vision. And you can see here there's a 16-bite radial keratotomy. And when you do topography, you see that the cornea is markedly flattened. But that's not the whole story. The whole story here is that not only was the cornea markedly flattened, but the cornea changed shape during the course of the day. And here you can see that the patient wore 3 different pairs of glasses during the day due to visual fluctuation. They were a +8 in the morning and a +5.25 in the evening. So how would you manage this patient? Well, the first step is to minimize the fluctuation. And here you can see the patient at night, and here you can see the patient in the morning, 3 diopters flatter in the morning. So what we did is we cross-linked this patient with the epithelium on, and we find that cross-linking dramatically reduces visual fluctuation. We've been very successful, and for small incision RKs, like 4 incisions, it really eliminates the fluctuation. 8 incision RKs, maybe 1/4 to 1/2 a diopter. In this case, it reduced the visual fluctuation markedly in the patient, but it didn't eliminate it completely. So now 3 months after the cross-linking, the patient's fluctuation was reduced from 3 diopters down to 1.5 diopters. So how did I manage that patient? Well, this is a classic example. I placed the apthera lens in, and here you see the lens opening up. There's the nice pinhole centrally. We rotate the lens into position like a conventional lens. We remove the viscoelastic behind the lens, in front of the lens as well. Put the lens into place. And now we're ready to send the patient home. We center the pupil on the visual axis, looking at the Purkinje images, and hydrate the wounds. By aiming for -75 at night, the patient was a -75 at night. And because of the 1.5 diopter visual fluctuation, the patient became a +0.75 in the morning, still having a 1.5 diopter swing. But because this lens can manage 3/4 of a diopter of sphere and still have 20/20 vision, the patient was still 20/20 at night and 20/20 in the morning. The only difference was that at night, the patient can read without glasses because they're -75 plus another diopter of reading. So they really can read beautifully at night. In the morning, when they're +75, they lose their reading and they have to wear reading glasses. But for a patient who's originally a +8 at night sorry, a +8 in the morning, to go from a +8 in the morning to Plano in the morning and only having to wear reading glasses, this was an extraordinarily happy patient. So that is my overview of different lenses that can be used: monofocal lenses, extended depth of focus lenses, monofocal plus lenses, and finally multifocal IOLs. And I'd like to thank you for your attention.
Thank you so much, Professor Donnenfeld, for another incredible session. We're going to pull that QR code up on your screen again if you'd like to claim your CME certificate. This has been our final CME talk for today. We've got a short message from a patient advocate, which will be great if you could stay for whilst you're filling in your CME certificate. But if you'd like a CME certificate, just scan the QR code there, and you'll be able to claim your CME certificate. I'm going to leave that on the screen for a little second whilst you do that. And there's a link in the chat box on the right-hand side. If you're on desktop, on the little message icon, if you click on that on mobile, you'll get the link in your mobile chat box as well on MedAll. If you're joining on one of the other platforms, you can scan the QR code. We'll also send the link out via email, so you'll get the link in your emails. And we'll also make this content available on demand, so you can watch it anytime if there's something you want to catch up on. And it's been an incredible masterclass. We've covered a lot of ground this morning, and we're really grateful to Professor Donnenfeld and Professor Riaz for guiding us on some of the most important advances in presbyopia-correcting IOLs. So we're going to move on to our final talk today, which is a really important message. It's a message from a patient called Brenda Nickham, and she's going to be sharing her perspective as a patient having had presbyopia-correcting intraocular lenses. I'm going to hand over to the interview that I had recently with Brenda Nickham. I am really honored to be joined by Brenda Nickham today. And Brenda had presbyopia-correcting intraocular lenses when she had cataract surgery in April 2011. Her surgeon created a blended vision monovision profile, one eye optimized for distance, the other for near work. And several months later, posterior capsule haze developed, and she underwent laser capsulotomies on both eyes in November 2011. Brenda, it's great to have you join us, and thank you for sharing a little bit about your journey.
Thank you for letting me speak with everyone. I appreciate that.
I'd love to hear a little bit about what vision challenges motivated you to consider intraocular lenses back in 2011, and what impact were they having on your life at that time?
So I had always worn glasses since the age of 2. As I grew older, I noticed more haze in my central vision. I have restricted peripheral vision as I have retinitis pigmentosa, so I wanted to make sure that I could maximize the usable vision I had for as long as I could. So that was what led me to investigate the cataract surgery itself. I had no idea at that time about the option for having prescription or a corrective lens like that implanted. And so when I learned about that, I decided that that would be the best way to go.
And was there anything that you wish you had known before the surgery, or anything that could have been improved about your experience?
Sure. Yeah, absolutely. I had the first eye done, and then I spoke with my physician, and I was like, I'm not sure about this. It doesn't seem quite as clear as I thought. And this was pretty soon after, but he made the decision at that time to use the blended lens, so that I had one for distance and one for up close. I wish I had known how that would impact me and my depth perception, and my ability to pass my driver's license eye test. That presented some challenges. But overall, I had a very pleasant experience. I see better now than I ever did without glasses. So,
and we're going to come on to that because it's really important, the long-term outcome you've had, and I'm really looking forward to hearing more about that.
Mhm.
Would it be possible to describe what the first week was like after your cataract operation?
So the day of and the next day, just had a little bit of feeling of pressure, little flashes of bright light, I think, from that intense light during the procedure, a few floaters, but that quickly subsided and the pain went away. Each day got progressively better, and I was very excited to look down at the ground and see blades of grass, and it honestly brought tears to my eyes. I just had never experienced that clear vision without corrective lenses on my, in glasses.
A lot of patients worry about glare or halos. What visual phenomena, if any, did you notice, and how long did that take to settle?
I would say within the first week or so, I made sure that I wore, protective sunglasses, went out in the sun, and, just limited that time. But I was driving within a few days, and no real challenges there. The floaters and things didn't really prevent me from doing anything, or even those halos. So very short-lived and quickly resolved.
And you beautifully told us that you had tears in your eye when you first saw those blades of grass. Tell us a little bit more about those emotions. What emotions did you feel the first time you could read a menu or a street sign without glasses?
Well, to be honest, the most exciting part for me was being able to buy a pair of sunglasses that didn't have to fit over or clip on my prescription lenses. I still remember going to the store and picking out about 3 pairs that made me feel more confident. And it was just a kind of a sense of freedom from those glasses. So I was used to rolling over in the morning, and I couldn't do anything without grabbing my glasses and putting those on. So being able to get up and move freely, and it was just very exciting.
It's amazing, that kind of quality of life impact.
Mm-hmm.
And then we touched on it a little bit at the start, and you ended up having capsulotomy treatment. Would it be possible to tell us a little bit, how did you recognize you needed that? What was the procedure like?
Well, the physician was very clear that was a possibility. So when I started to notice a little fuzziness in the central vision, I thought, wow, I better, get this checked out. And to be honest, because I had met my deductible for the year, I really kind of pushed to get it done sooner rather than later. So they, got me in. It was probably September when I realized that, it was starting to get a little bit fuzzier. So I'm not sure if they normally do it that quickly after, but they graciously got me in and did the procedure.
And can you tell us a little bit about, did the capsulotomy alter any of the visual side effects you'd adjusted to after the original lenses?
Well, the procedure itself was a little unnerving because it wasn't sedated like I had been during the initial surgery. So I sat upright in the chair with my head secured to the machine, but I had to be very conscious about not moving. And you never need to blink until somebody says, don't blink. So it was very unnerving. The procedure went well. I had a little bit of pressure feeling, but not really major discomfort during the procedure. The complications came in after. The doctor was very clear not to touch my eye. There was the gelatinous substance, that protected the eye during the procedure. I had kind of wiped a little of that out of the corner of my eye, and that was the only time I really went near my eye. When I got home that evening, I had severe discomfort. It really felt like I had shards of glass in my eye. And I thought, okay, this probably is just the eye healing. I went to work, tears running down my eye all day. Finally called them, and they got me in right away, and I had scratched cornea. So they put the numbing drops in, did the examination, determined it was scratched, put a Band-Aid contact on, and I felt fine immediately once they put the numbing drop in. So when we were preparing for the second eye, I was like, okay, this is not going to happen again, is it? Because that was horrible. No, it'll be fine. Just don't go near your eye. So the second procedure was completed. I didn't touch anything near my eye, and I got home, the same immediate discomfort. So I got in right away, same scratched cornea, Band-Aid on, and I was fine. So no long-term complications from that, but that was just something that I had not expected.
And you touched on long-term there. I'd love to hear, more than 10 years on now,
Mhm.
how do your distance and near vision compare with what you expected?
It's still wonderful without glasses. I obviously, 14 years in, I'm almost 55 years old. You have the normal aging process and the complications of the retinitis pigmentosa, but the only time I wear glasses is basically for long distance or reading fine print. I do have a pair of computer glasses just kind of for protection and kind of sharpens things up a little bit. But I still am very pleased with the outcome.
And it makes an impact on your life, right?
It does.
What hobbies or work routines have changed because of the visual freedom the lenses have provided you?
Yeah, just having that clarity to be able to do. I work in an office doing computer work. It was always difficult with glasses to kind of get that, given the screen distance and things like that. So I don't really have any issues there. Hobbies, I enjoy gardening and fishing. And so kind of being able to see that line to tie your knots and weeding the garden. And so it's just that kind of freedom from having the glasses on all the time. Sometimes swimming, that's another thing that kind of freed me up from the glasses.
And I'd love to hear, you've really graciously joined us here on the Ophthalmology Academy today. We've been learning about loads of science, and we find these interviews really bring it home as to why is this important, and it's because of the patient at the end of the day. But I'd love to understand what's motivated you to lend your voice to the Ophthalmology Academy today.
Well, I am a huge advocate for those with vision loss, and being able to give some personal perspective on the experience. I work in a field that works directly with those with vision loss, and I do hear stories of doctors who are very cut and dry. This is the facts, with a little bit lacking in compassion and kindness. My doctor was very professional, very well known for his expertise. Not exactly the greatest bedside manner, but I think just having kindness and compassion and clear communication on expectations. I understand that each person is going to be different in how their treatment progresses, but trying to provide as much information as possible.
From your experience, Brenda, how can surgical teams better support patients during that neuroadaptation period right after lens implantation?
Just again, like I said, I know it's going to differ from patient to patient, but just giving clear expectations and kind of as close timeline so that they know what to expect as they're healing and how things progress.
And if you could give one call to action to both clinicians and patients to improve cataract surgery outcomes, what would it be?
For me personally, if you're going to do the blended vision, please explain what that will mean and what kind of complications that might add. That would have been huge to me. I might have decided to just do the distance or just do the up close. So, yeah, just clear, reasonable expectations for how things will play out, and again, that kindness and compassion.
Brenda, thank you so much for joining us, sharing a little bit about your journey, a little bit of your story. This means the world to us. It means the world to our colleagues who are joining us to really bring it home about why we learn what we're learning, and that's all about the patient and the change in their life at the end of the day. So thank you so much for joining us. I really appreciate it.
Thank you again.
I hope you found that a really powerful conversation with Brenda. I certainly did, and it's a really important part of our education. It's been a pleasure to have you here today and to join us. I hope you find it really useful. We would love to see you at another MedAll education session sometime soon. They're all free. They're all open access. You can go to medallaeducation.com and you'll be able to scroll through hours and hours and hours of free online CME CPD for colleagues around the world. And that's what we're really passionate about. How do we make this type of education open access and essentially drive better patient care? So it's an honor to have you join us. It's been our pleasure to host you today. That QR code for your CME certificate is on the screen. The link is in the chat box on the right hand side. If you are joining on desktop, click the little message icon at the bottom. If you're joining on mobile, you'll get the link to complete your CME certificate. If you're joining on one of the social platforms, you can scan that QR code. You just need to either sign in or set up an account, and you'll be able to claim your CME certificate, and it's completely free. We'd love to hear your thoughts, your feedback. Please tell your colleagues about our education. The more, the merrier, and we'd love to welcome you back next time. I hope you find today really useful. It's certainly been great to host you. Have a great rest of your day, and thank you for joining us.